Hello, I'm Rebecca Gladdy. I'm a surgical oncologist at the University of Toronto, and I'd like to thank the organizers for allowing me to discuss the role of multidisciplinary care in complex desmoids. I have no disclosures, and I've had a longstanding interest in trying to minimize surgical intervention in this benign condition. I have two main objectives in my talk. The first is to discuss the role of multidisciplinary management in desmoids, especially in harder to treat FAP patients. And secondly, I look forward to brainstorming on future directions that need to be developed for our patients. As this audience well knows, desmoids are benign tumors that have an indolent range of biology to locally aggressive. This occurs in three main patient populations, sporadically in the peripartum period, and also in association with the familial condition FAP. Historically, surgical intervention was recommended for our patients, but this has evolved over the past decade. In the Toronto Sarcoma program, we've been committed to managing desmoid patients, and we're the largest program in the country. And we also provide provincial expertise by hosting regional tumor boards. This allows us to engage in expert patient care and research. And we're quite committed to training fellowships in pathology, radiology, surgical disciplines, and also medical and radiation oncology. We host the largest maternal fetal program in Ontario, which is important for our pregnant patients. And also, over 40 years ago, we established the Familial Gastrointestinal Registry, where the FAP patients are primarily managed. So I'd just like to thank the Desmoid Tumor Foundation of Canada for their championing this disease for our patients, and also being very active in collaborating with DTRF for generating research funding so that we learn to better manage the disease overall. Several years ago, our group in Toronto reviewed our institutional experience, and this was published in the Annals of Surgical Oncology. And over this 30-year study period, we looked at this heterogeneous group of patients, including peripartum and FAP patients, and we had over 213 patients that were stratified into three main groups. And these three main groups were stratified based on whether or not we saw primary disease, which is 83% of our patients, whether they were initially treated in an outside hospital, which is about 10% of our patients, or those patients within house that recurred. And I'm not going to focus on all the details of this, but really just to highlight that in this study several years ago, these were intra-abdominal and abdominal wall tumors. And we found a more favorable outcome associated with those with pregnancy associated. And we also looked at those particular FAP patients. And the disease outcomes we looked at were more typical cancer outcomes, which I think we all appreciate need to evolve for our patients. So here's the overall cohort, and over time, we switched to an observation alone approach for those patients that initially presented to us. And when they progressed, medical therapy or on occasion surgery, and rarely radiation was actually used. And for patients managed at outside centers, often that were microscopically margin positive, continued observation was safe. And for our recurrences, we also are really engaged in a close observation approach, and this was also safe for this patient population. So over half of our patients did not require any intervention with prolonged follow-up. We found in multivariable analysis that tumor site and size may predict progression. And we're very interested in the context of our global desmoid community of working towards defining biologic markers that will help us better counsel patients at presentation. Our team is also in collaboration with Dr. Fiore and Dr. Rout, and also Dr. Bonvalo, been very interested in the management of peripartum abdominal wall desmoids. And it certainly occurs several times a year that one of our team participates in C-sections where there's a desmoid of the abdominal wall. And we continue to counsel our peripartum patients that this condition is not something to be alarmed about, that subsequent pregnancy is safe and is able to be managed. And we also work closely with the obstetrical community to avoid extensive surgical intervention in this patient population, as the spontaneous regression is usually what is identified. Several years ago, I was fortunate to participate in the global management consensus guidelines. And based on this expert evidence-based literature review, we all agreed that gold standard is active surveillance for our patients, and that surgery was important to be engaged in for patients that had life-threatening conditions such as bowel perforation or obstruction, when patient preference predominated, or when there were symptoms that weren't well managed by medical intervention. We do on occasion in Toronto use radiation, but really for difficult to treat sites such as extremity and head and neck. And that's really in the medical refractory disease state where amputation, for example, might be required. What was identified as a challenge that we don't yet have a good handle on is those challenges faced by FAP patients. And that's really what I'd like to focus the rest of my talk on. So Isar Al-Sukni in our team at the University of Toronto recently reviewed our single institutional experience with respect to the management of FAP patients so that we would better understand when we needed to intervene and how we actually intervene in trying to deal with this more complex disease in patients. And so as many of you know, this occurs in about 10 to 15% of FAP patients. And, prior to the 2000s, surgical intervention was published and was really associated with some pretty morbid outcomes of short gut, high rates of recurrence, and also death directly related to surgical intervention. And with this ongoing appreciation of more challenging biology, people have really switched to observation and medical therapy, which I'm going to discuss. An important thing to note for the field is this higher incidence of paradoxically developed disease post-laparoscopic colectomy versus open. And that's something that we're thinking about with our colorectal colleagues. So Isar looked at basically a 20-year period in our institution. We collected standard demographic data, and we also classified the multiple tumors by typical body site in desmoid disease. And in this particular table, we identified 45 patients, 13 of which had disease at multiple sites, and certainly a younger patient population. And by far and away, these patients developed desmoids following their colonic surgery for their polyposis syndrome. Some of these patients were symptomatic, 3/4. And of those, about 1/4 of patients became severely symptomatic. And what we mean by that is that they had recurrent small bowel obstructions requiring hospitalization. They developed abscesses or fistula, ureteric obstruction requiring intervention. And these are the patients that we really worried about. We also looked at the number of interventions patients required and the nature of the interventions that the multidisciplinary team used. So this is a fairly complex slide here, and we'll be presenting this in detail at CTOS, but really we wanted to highlight that overall many patients began off with observation when they presented to the sarcoma team, that chemotherapy and other systemic therapy were really the main interventions that we used, avoiding surgical intervention for patients that really necessitated it because of significant surgical reasons. And as those progressed on observation, chemotherapy was used and very rarely radiation therapy. I also want to highlight a really nice recent paper by the European group that focused on medical management of FAP desmoid tumors. And in this study of over 37 patients, medical therapy, which was very similar to our cohort, consisted of methotrexate and vinorelbine, which was very well tolerated by the patients. Over 50% of their patients had at least a partial response to treatment, and over 95% of them had good disease control. And they also identified that rechallenge with methotrexate and vinca alkaloids was successful in this patient population. So some of the additional findings from our study that is time limited for us today is the fact that we were able to control desmoids with one or no intervention in about 3/4 of our patient population. In 34 patients, they had stable disease or some regression after an international intervention. And in those patients where the disease actually progressed, the majority received chemotherapy, and of those, 83% remained stable with no need for further intervention at a follow-up of 2.7 years. In those more worrisome patients that were severely symptomatic, 4 of them had ongoing needs for intervention, obviously at times with interventional radiology, trying to avoid surgical procedures for desmoid tumor control. And importantly, overall, at 6 years, 73% were alive with disease, 16% had no evidence of disease. And unfortunately, 11% of those patients died of non-desmoid tumor-related causes. So I'd like to summarize our experience that in those patients with favorable biology, we do limit surgery and have a preference for those that progress with medical therapy. There are times where surgery is needed for patients who have rapid growth and we're concerned that we'll lose the window for resectability. We try to clear the surgical margins, but in our experience, that's not particularly critical. And finally, we do certainly avoid surgery in FAP patients, but there are times where this is warranted, obviously to save their lives. But overall, they are very responsive to the current medical agents. And we certainly look forward to defining molecular markers to predict biology and better targeted agents for our patients. So I'd like to thank you for your